Hello, everyone. Dear distinguished speaker, APASL members, colleagues, and friends around the world. Welcome to session 4 of the APASL School of Hepatology e-learning platform, which will be held every last Tuesday of the month. And this is the fourth sessions of series 1 of the APASL School of Hepatology. And this platform allows us to educate young doctors, fellows, thanks to the guidance of Professor Shiv Sarin, Chair of Steering Committee of the APASL, and hard workings of Professor Maitreyi to invite all the prominent speakers from around the world. And I hope that this program will be beneficial to everyone. Please do not hesitate to ask the questions and comment to the speakers by typing in the chat box. APASL annual meeting will be held in Bangkok from February the 4th to the 6th, 2021, with this digital platform. Please visit the website of the APASL 2021. Lastly, I would like to thank all distinguished speakers, moderators for being part of this program. Today, we are so honored to have 3 moderators. All of them are past presidents of the APASL, including Professor Shiv Sarin, Chair of the Steering Committees, Professor Docmeci from Ankara, Turkey, and Professor Diana Payawal from Manila. So happy holiday. I will pass my role to Professor Shiv Sarin to introduce the speaker. Thank you.
Thank you, Professor Tanwande, and it's a great opportunity for us to close the year with 3 ladies in today's program. So we have overcome the gender bias. Today is the day where we have 3 very distinguished speakers for this session on how to do nutritional assessment in liver disease. We have the first speaker in this session is Dr. Maitreyi Raman, and Dr. Maitreyi Raman is an MD, is also an FR CPC and CAGF. She comes from Canada, and she is a gastroenterologist. And what I find very interesting is a physician nutritionist. You know, all of us thought that we know nutrition, but to be decorated as a physician nutritionist is something actually requires exceptional talents. She has a long list of awards and work done. And an interesting area for us is to know that she has worked on parenteral nutrition in liver diseases, which is a challenge for most of us. Today, she will be speaking on nutrition screening and assessment tools, including composite tools and dietary assessment in liver disease. I can only say that it's an area which is very close to my heart, and all our students, colleagues, and faculty across Asia are waiting to hear you, Dr. Raman. Welcome to APASL E-School of Learning. Thank you.
So thank you very much for the opportunity today to talk to you about an approach to nutrition screening and assessment in cirrhosis. And thank you, sir, for that very kind introduction. So the objectives of today's presentation are to describe the rationale and urgency to determine nutrition status in patients with cirrhosis. Describe the role for nutrition screening and available evidence for cirrhosis-specific screening tools. And finally, to discuss the evidence and implementation for nutrition assessment in cirrhosis care. A few years ago, we conducted a Canadian-wide national study to explore the prevalence of malnutrition in patients admitted to Canadian hospitals. In over 1,000 patients from 16 different hospitals across the country, we identified that 45% of patients experienced either moderate or severe malnutrition. However, when we looked at discharge summaries or progress notes nutrition or particularly malnutrition diagnoses were only captured 1% of the time. When we look specifically at patients with cirrhosis, the figure of patients experiencing malnutrition is much higher, approaching 75 to 90%. However, we very seldom typically routinely recognize malnutrition as a problem among our cirrhotic patients. Now, a few years ago, Dr. Tandon and myself, we published a paper in Hepatology reporting on the prognostic implications of malnutrition in cirrhosis. And we reported on the fact that this is in fact one of the most common complications of cirrhosis. And it's very important to identify this because potentially this is a modifiable factor. We see here that malnutrition, including muscle depletion and sarcopenia, is an independent risk factor for multiple adverse complications such as recurrent ascites, bacterial infections, hepatic encephalopathy, and overall this translates towards poor survival. Now, in our Canadian study, we also identified that patients presenting to hospital with either moderate or severe malnutrition incurred much greater hospitalization costs, approaching $8,000 per hospital visit, compared to only $5,000 in the well-nourished patient. Similarly, in terms of length of stay in hospital, malnourished patients on average experienced a significantly greater stay, approaching 12 days in hospital compared to 8.5 days for the well-nourished patient. Now, particularly in cirrhosis, identifying patients with cachexia and sarcopenia is very important because this is in fact a multifactorial condition. And addressing multifactorial targets may be the overall solution towards improving clinical course and preventing further decline. Now, specifically in the setting of cirrhosis, we see a group of patients that present with anorexia, as well as low-grade inflammation, hypermetabolism, in addition to factors such as disability, immobility, and accelerated starvation, including decreased protein intake and altering utilization of substrates, together lead towards the presence of sarcopenia and overall impair the clinical course for patients. Now, specifically in liver cirrhosis, in addition to accelerated starvation, which translates into increased amino acid utilization, more limited oral intake, particularly of dietary proteins, we see other factors such as the presence of endotoxemia, hyperammonemia, all of which contribute towards altered proteostasis and muscle depletion. And other factors such as hormonal impairment have a role to play in the pathogenesis of sarcopenia as well. Now, typically when we think about nutrition screening, we think about a very simple and easy to execute tool that anybody without any specific expertise should be able to apply in a valid and reasonably quick fashion. Now, the recommendations for most organizations are for nutrition screening to occur at the time of hospital admission. So because of the multiple types of disease etiologies that present to hospital, screening specifically with a cirrhosis-specific tool may not be possible at an institutional level. So there has been interest in looking at generalized nutrition screening tools that can be applied at an institutional level to see how well these tools function. And should they have any shortcomings, then potentially the need for liver-specific nutrition screening tools becomes that much more important. So when we look at generalized screening tools that can be applied to any patient population, there are multiple examples of these, two of which I share on the screen here. First, on the left, the Malnutrition Universal Screening Tool, otherwise known as the MUST, and on the right, the Nutrition Risk Screening Tool 2002 on the right. You'll quickly find here that the two biggest criteria to apply for this screening tool are the body mass index, which of course considers weight, in addition to weight loss that is transpired over the preceding 3 to 6 months. Now, undoubtedly, in patients with liver cirrhosis, many patients do have concerns with water weight management. And because of fluid overload, neither the BMI nor the weight loss may be applied in a valid manner. Similarly, when we look at the NRS 2002, the major criteria also focus on body mass index as well as weight loss over differing periods of time. Again, questioning whether or not the validity of this would apply to patients with cirrhosis and hypervolemia. Now, to overcome some of these barriers regarding weight and weight change, over the past few years, two specific liver cirrhosis specific nutrition screening tools have been developed. On the left, you'll see the liver disease undernutrition screening tool, otherwise known as the LDUST. And on the right, we have the Royal Free Hospital Nutrition Prioritizing Tool, otherwise known as the RFH-NPT. Now, the liver disease undernutrition screening tool perhaps looks a little bit more complicated than the previous screening tools for the general population that I shared. But in fact, this can be completed reasonably quickly in under 2 minutes. And the questions here include a more diverse group of questions and consider things like dietary patterns, how well patients have been eating lately. There is a question about weight and whether patients have experienced any weight loss. But in addition to that, there are other factors such as notice of loss of body fat, loss of muscle wasting, and they also consider whether or not patients have fluid in their abdomen and or legs as a factor to interpret when assessing a nutrition risk score. And finally, the LDUST also focuses on general functional activities. Now, in the case of the RFH-NPT, right up front, we declare whether or not patients have fluid overload or not. And if they do have ascites or peripheral edema, then the questioning takes another path whereby weight is not considered. Where in the setting whereby patients don't have fluid overload, they follow a more traditional nutrition screening plan. And then finally, these questions are interpreted to offer an overall risk score. Now, until recently, these tools have been nicely proposed, but they have been subject to very limited validation. Now, last year in 2019, this group of investigators published in the British Journal of Nutrition on the role of the effectiveness of 8 screening tools in detecting risk of malnutrition in cirrhotic patients. And they compared the risk of these tools to the gold standard subjective global assessment. Now, arguably, there are multiple limitations associated with the subjective global assessment, but for the purposes of this paper, this was the chosen gold standard. So in addition to assessing the effectiveness of these 8 screening tools to detect malnutrition, the authors also assessed the predictive validity of these tools of predicting 1-year mortality. Now, for this study, they recruited 179 patients, 97 males, with a mean age approaching 60 years. The diagnosis of cirrhosis was made either by FibroScan or in the clinical picture of decompensation. Patients were excluded if they had hepatic encephalopathy, hepatocellular carcinoma, other cancer syndromes, or malabsorption. And all patients completed the 8 nutrition screening tools in addition to the subjective global assessment. Now, according to the subjective global assessment, the prevalence of malnutrition for this study was 23%. And this study did include both compensated as well as decompensated cirrhotics. And you see here on the far left, the multiple nutrition screening tools that were investigated. Now, the first 6 of these screening tools are general screening tools for general medical populations. And we have the 2 liver-specific tools at the bottom. And here, when we specifically look at sensitivity, and remember, sensitivity is the most important factor that we typically look for when we think about a screening tool. And we see that both the liver-specific screening tools had very high sensitivity, approaching 95% or greater. But when we compare the performance to the other more generalized screening tools, we see that these perform far less robustly, with sensitivities ranging from 46% to 71%. Now, the gold standard subjective global assessment was an independent prognostic factor of within 1 year mortality when adjusted for important confounding factors. Now, when we look specifically at the nutrition specific screening tools, we see that only the RFH and PT predicted mortality within 1 year compared to any of the other nutrition screening tools that were assessed, including the liver disease under nutrition screening tool. So the authors concluded that from the 3 tools that were evaluated regarding mortality outcomes, only the risk of malnutrition according to the RFH NPT tended to associate with mortality after adjustment for confounders. Now, in another study just published earlier this year, 155 cirrhosis patients without hepatocellular carcinoma were enrolled in another prospective study and followed up for 1.5 years. And here, multiple nutrition screening tools were administered to these patients, including the general screening tools, the NRS 2002 and the malnutrition universal screening tools, in addition to the 2 liver-specific screening tools. And for this study, the authors used the Royal Free Subjective Global Assessment as the gold standard tool. And I'll talk to you about this in a few minutes, but the Royal Free Subjective Global Assessment is a nutrition assessment tool, which is liver specific, unlike the SGA, which is which performs well in a non-liver generalized population. And here in this study, we see examples of the 2 Kaplan-Meier curves here on the left, the top for the NRS, the performance of the NRS 2002, and the bottom for the performance of the RFH NPT. And we see what happens with mortality over time when patients are subdivided into either low risk for malnutrition in the blue or high risk for malnutrition in the orange. And we see that malnutrition status, or the NRS 2002, does not separate or predict mortality over time. However, in the case of the RFH NPT, we see that patients that are low risk for malnutrition have an overall better survival rate compared to those that are high risk for malnutrition. And in the multivariate regression, whereby there were multiple factors inputted into the multivariate model, including factors such as mid-arm muscle circumference, tricep skin fold thickness, and multiple biochemical parameters, only the Royal Free NPT score at inclusion was predictive of overall mortality, leading the authors to conclude again that perhaps liver-specific tools, and in particular the RFH NPT, might be a worthy nutrition screening tool for application to patients with cirrhosis. Now, moving on to nutrition assessment. So I've told you that nutrition screening is meant to be completed by any healthcare provider without any specific expertise, and it should be highly sensitive and capture the highest risk patients for malnutrition-related outcomes. Now, in contrast, nutrition assessment is meant to be the gold standard method of formalizing the diagnosis of malnutrition. And there are many definitions for malnutrition, which makes this concept of malnutrition very challenging to try and quantify using specific definitions. But in this meta-analysis that our group published a couple of years ago, we identified that regardless of how one defines the term malnutrition, better nutrition status predicted overall better outcomes. Now, in the study that our group published last year, we tried to better understand what the current state of the literature regarding nutritional assessment tools and how these predict outcomes. And here we can basically say that nutritional assessment tools can be broadly classified into 4 categories. So for application at the bedside, there are bedside global assessment tools, such as the Subjective Global Assessment and the Royal Free Hospital Subjective Global Assessment. Nutrition assessment can also include bedside single measurement tools, such as the mid-arm muscle circumference and hand grip strength, which are surrogate measures for muscle mass as well as muscle function. Now, beyond these tools, we can also consider non-cross-sectional imaging based body composition tools to better understand the body composition situation. We can use tools or imaging such as bioelectrical impedance and the DEXA scan. And finally, and arguably, the gold standard assessment of sarcopenia would be cross-sectional measures. Now, although clearly associated with prognosis, as I've shown you on the previous slide, the definition of malnutrition and its assessment are in evolution. So this systematic review was to summarize the definitions of malnutrition and the evidence for various nutrition assessment tools to predict clinical outcomes. Now, first and foremost, looking at cross-sectional measures of sarcopenia, we see that this has been subject to multiple rigorous studies. And in a pooled analysis of 7 studies, sarcopenia was a significant predictor of mortality using cross-sectional measures. Now, recognizing that cross-sectional measures are not universally available and they are subject to a significant cost and possibly radiation exposure depending on the tool used, attempts to use surrogate markers of muscle measures were also explored. And we see here that only 2 studies utilizing hand grip strength and its ability to predict pre-transplant mortality were identified for the purposes of this review. However, in both these 2 studies, the pooled analyses suggested that hand grip strength was a significant predictor of mortality. Now, recognizing that hand grip strength also requires specific tools such as the hand grip dynamometer, there is interest in looking at more general global tools which can be applied at the bedside without specific cost or additional resources required. So there were 3 studies that identified that the Royal Free Global Assessment Tool was indeed a significant predictor of mortality. And recognizing that the Royal Free Global Assessment Tool has multiple components and may require a level of sophistication beyond the traditional subjective global assessment studies, of which there were 3, also identified that this tool was a significant predictor of mortality. Now, multiple groups have reported that the subjective global assessment, however, may not have the level of sensitivity needed to pick up most patients with sarcopenia. And this, of course, is an ongoing struggle for which this field requires further literature and study development. Now, Dr. Tandon and her group nicely published on this as far back as 2012. And even 8 years ago, her group was able to identify that sarcopenia compared to non-sarcopenia was, as diagnosed via cross-sectional imaging, was an independent predictor of survival. And again, looking at how we can bring this back to the bedside, they tried to describe how dry weight body mass index, after controlling for fluid status, how this predicted sarcopenia. And here we see that in both female and male patients with a body mass index less than 18.5, universally, all of these patients were sarcopenic. However, even when we look at overweight patients with a BMI greater than 25 after controlling for dry body weight, still over 40% of male patients remain sarcopenic, therefore leading to the conclusion that BMI alone, if you rely on that without other measurements, may have inadequate sensitivity to pick up sarcopenia. Now, I put this slide up here to show you what the Royal Free Subjective Global Assessment in practice looks like. Now, this is a very nice and elegant tool and utilizes multiple factors in order to make a diagnosis of malnutrition. But you can see it is quite complex. It does take time-intense resources, and it requires specialized tools and specialized expertise. So at the outset, body mass index is considered, and then patients follow down pathways based on BMI, either less than 20 or greater than 20, followed by the measurement of the mid-arm muscle, and then followed by dietary intake. And after these things have been considered, overall, the diagnosis of malnutrition has been made. So ideally in the gold standard situation, this would be perhaps arguably the best bedside global assessment tool to consider. But I think for the reasons mentioned here, still this tool remains a challenge to implement into practice due to the intensity of resources required. Now, finally, I'd like to talk to you a little bit about the concept of sarcopenic obesity. Now, you're well acquainted with the term of sarcopenia, but when we typically think of sarcopenia as well as obesity, particularly visceral adiposity combined, arguably the clinical consequences of this are even more deleterious. So we see an example of, on the bottom here, of two patients with very similar body mass indices. However, on the far left, we see that this red, which represents the skeletal muscle, is much depleted compared to the patient on the right. But in contrast, the presence of this diverse yellow is much greater than the patient on the right. So here we see a patient that has low muscle mass and high visceral adiposity, and this patient would be coined as having sarcopenic obesity. And this co-occurrence of both obesity and sarcopenia can have very significant complications and effect on clinical course. And we frequently see this phenotype of patient in those suffering from NASH-related cirrhosis. Now, identifying these patients in practice remains challenging. And although we can suspect this with the diagnosis of NASH, truly confirming their nutrition status remains challenging. Now, the APASL clinical practice guidelines were released last year, and I put them up here for your review. And here we see that according to these guidelines, patients with Child-Pugh cirrhosis automatically are considered high risk for malnutrition. So these patients automatically, the recommendation is for a detailed nutrition assessment and or a diagnosis and or a cross-sectional diagnosis for sarcopenia. Now, while measures of sarcopenia may not always be present from which to calculate risk, the detailed nutrition assessment can certainly always be applied, and the recommendations from the APASL guidelines are to consider either the subjective global assessment or the Royal Free Hospital global assessment together with dietary intake assessment. Now, when patients may be diagnosed as having malnutrition, in which case various intervention recommendations are recommended. And if they're determined not to have malnutrition, then the recommendations are for follow-up and rescreening at least on an annual basis. Now, finally, I believe that this topic will be covered in much more detail in a later talk, but I'd like to close by stating that the dietary management of patients with of malnourished patients with cirrhosis truly is a multidisciplinary sport, and multidisciplinary engagement is critical in order to have the best outcomes. An assessment of dietary intake by a trained professional is critical and forms the basis from which all other assessments can flow. And dietary intake can be assessed either using a 24-hour recall, validated food frequency questionnaires, or 72-hour food records. Typically, your nutrition professional or registered dietitian would carry out these records. In addition, attention to diet quality, dietary timing, number of meals daily, barriers to eating, including food access and food security and clinical symptoms, are important in order to make a fully informed diagnosis of dietary intake and its enablers and barriers. And the diet recommendations are truly based in pathophysiology and build upon the accelerated starvation as well as hypermetabolism factors, which are known to have a role in the pathogenesis of muscle depletion in cirrhosis. And typically the recommendations in malnourished patients are to aim for 30 to 40 kilocalories per kilogram of dry body weight, and between 1.2 to 1.5 grams per kilogram of protein of dry body weight, with a focus on frequent meals, nocturnal meals, minimization of prolonged fasting, ensuring patients have adequate ability to chew, that their teeth are functional, their dentures fit properly, and that their symptoms, particularly their nausea, vomiting, early satiety, which may arise in the context of ascites, are adequately managed. In the inpatient setting, minimizing prolonged fasting, ensuring adequate education of the patient, the families, as well as the providers, managing food insecurity, and then finally diet quality are all very important. And particularly, again, in the inpatient setting, there is or may be a role for nutritional support therapy, and this includes both enteral nutrition as well as parenteral nutrition, and keeping the role for enteral nutrition in mind, particularly in patients that have expected prolonged duration of fasting, is critical among our inpatients. So finally, I'd like to conclude by stating that malnutrition is frequently observed in patients with cirrhosis. We need to make a concerted effort to identify malnutrition, and ideally do this using validated nutrition screening and assessment tools, because this predicts outcomes and possibly is amenable towards intervention, and nutrition interventions may change clinical outcomes. With that, I'd really like to thank you for your attention and for the opportunity to present to this esteemed audience today. Thank you.
Thank you so much, Dr. Raman. It was very enjoyable. I have a few questions from the chat box, and I have a couple of questions myself. One question is, which of the tools you would like to use for patients who are ventilated with cirrhosis and critical illness?
That's a great question. So in particularly the ventilated group of patients, I would recommend exclusive enteral nutrition. In our critical care units in Canada, and I suspect globally, the evidence and the data for enteral nutrition compared to parenteral nutrition is superior. Enteral nutrition also has fewer long-term complications, particularly metabolic complications, and it does reduce the risk of sepsis and infectious complications. So enteral nutrition formulas would be preferable to parenteral nutrition formulas. And ideally in the critical care setting, if you have availability of an indirect calorimeter to inform energy expenditure, that should also be considered, because the energy requirements of this patient population is challenging to determine simply using clinical measures alone.
I have
just to introduce the person, Varsha, who has asked, runs indirect calorimetry trolley, and she is a critical care nutrition PhD student and has done a very large number of patients, just for information's sake. And one more question from my side also. We have been using parenteral nutrition a lot, especially omega-3 and omega-6, and we had found that, and we presented 2 years in a row at ASLD, that it decreases inflammatory markers and of course converts negative nitrogen balance into normal or positive nitrogen balance. What are your thoughts on lipid emulsions in patients who are critically ill cirrhotics?
Yeah, that's another great question, and a very interesting question close to my heart as well. So I think that you've touched on a very important point, that lipid emulsions are much more than just a source of energy. Lipids are immunomodulatory in terms of their efficacy. And we have also previously shown that that monounsaturated fatty acid emulsions, in addition to omega-3 fatty acid emulsions and optimal omega-3 to omega-6 ratios, are important in terms of improving clinical course in any patient with liver disease. Now, my greater experience in using lipid emulsions arises more from patients who receive long-term home parenteral nutrition support. And as you probably know, that home TPN is a major risk factor for TPN-related cholestasis. So for those reasons, the clinical trials have also supported better outcomes for omega-3 based lipid emulsions compared with standard omega-6 based lipid emulsions. So your results are in keeping with my experience as well.
Okay. We have, Diana, some questions from your side.
Yes, Professor, can you comment on the use of the SPPP, the hand grip, and the 6-minute walk test, because you did not elaborate on this battery of tests that we usually use to assess the strength for frailty.
Sure.
How does it get into your picture of nutritional assessment? I think the students would be interested to know that.
Sure, and I wonder if I could ask my colleague, Dr. Tandon, to copy or to comment on the 6-minute frailty test or walk test, because I think she probably would have more experience than I would on that particular topic. And I think that might be a focus of her presentation as well.
Okay.
We can do that in the subsequent talk, maybe when Dr. Puneeta Tandon takes over. We have one more question in the chat box. Is amino acid index database, and that's a difficult question coming from Kenichi Shuniwa from reproductive immunology. Well, that's a fascinating name. I never knew reproductive immunology has amino acid index database. So you have any idea, Dr. Raman?
Oh, I must say I'm not familiar with that topic, so I don't have much to add.
Well, food for thought. It's a
Yes.
nutrition section. Good. And we have another question. What's the role of glutamine in seriously ill hepatic cases? Glutamine.
Glutamine. Okay. So that's right. I mean, there's lots of literature that has been reported on the role of glutamine. I think that, similar in terms of leucine as being an important amino acid to consider, particularly in the management of sarcopenia. I think the data for glutamine are, I guess they're there for particularly the critically ill patient. So for those patients that are ventilated in ICUs, there may be a role, particularly in the peri or post-operative setting and in the critical care setting specifically, to consider glutamine as a patient. I think for a routine supplementation of a decompensated liver patient with cirrhosis, the literature or the evidence for glutamine supplementation is more limited. However, in contrast, I think there can be consideration for leucine as supplementation as part of the treatment options for sarcopenia management.
All right, I think we're running out of time, and I would hand over to my very eminent colleague, Professor Kardir Docmeci, past president of APASL, to take the next session, and I would like to thank Professor Raman for an outstanding presentation. A round of applause. Thank you.
Thank you.
Thank you very much. Now the second speaker, Professor Jaya Benjamin. She's a young faculty with excellent academic record, presently working as an associate professor in the Department of Clinical Nutrition at the Institute of Liver and Biliary Sciences, New Delhi. Having 15 years of research experience with 17 publications and 11 book chapters to her credit. She's the principal investigator of 4 extramural research grants and guide for 3 PhD students and a co-guide for many students at ILBS. She is also the reviewer of the many indexed national and international journals and the Assistant Secretary of the Indian Society of Clinical Nutrition. Her main interest is nutrition in liver disease. Now, Professor Benjamin is going to talk about body composition assessment methods for detailed nutritional assessment in liver disease. Yes, Professor Benjamin.
To thank the organizers for giving me an opportunity to speak at this important academic event. And over the next few minutes, I shall be discussing about the methods of assessment of body composition in patients with liver disease, with special reference to the assessment of sarcopenia and cirrhosis. Well, this is the human body is typically composed of water, fat, proteins, and minerals, usually in this order of decreasing amounts. Now, when we all change in many ways, we change as we age, and we also change with the onset of any debilitating disease like chronic liver disease. Hence, in patients with liver disease, we may be interested in knowing the body composition or learning about the body composition if we want to characterize the body composition as a risk factor, maybe to diseases like non-alcoholic fatty liver disease, or we may be interested in assessing sarcopenia to more precisely define malnutrition in patients with chronic liver disease, or we may simply be interested in assessing the effect of any intervention program on the body composition per se in these patients. Well, the body composition may alter in terms of the total fat percentage, in the terms of fat distribution, the total amount of muscle mass, the muscle quality, or the bone mineral content. Now, the cliched method of estimating overweight, that is the body mass index, though it is very handy, it is very useful. It beautifully defines the underweight and the overweight, and it is also associated with increased morbidity and mortality. However, unfortunately, it does not differentiate between these two individuals who have the same BMI. It puts them at the same risk because the problem with BMI does not take into account the muscle mass. Hence, we need some more objective methods to precisely understand the body composition. We would be discussing about the principles, the advantages, the disadvantages, and the uses in liver disease in describing sarcopenia. Well, there are few methods like the bioelectrical impedance analysis. They divide the body into two compartments, and they give us the results in terms of fat mass and the fat-free mass. Whereas the other methods like DEXA, they divide the body into three compartments: the fat mass, the bone mass, and the lean body mass. The advanced methods like CT and MRI, they directly assess the muscle mass or the fat mass per se. Well, a number of methods are available, from the more complex ones to the simpler ones, but as the practicality and the applicability increases when we go in this order, certainly the accuracy and the precision decreases. Now, just to briefly touch upon the first method, which is the most primitive method, that is anthropometry, though Dr. Raman would be talking at detail on this topic. But all we need here is a skin fold caliper and a measuring tape. We measure these variables and put them into the equations, and we get the values. Now, anthropometry is very widely used in cirrhosis, and mid-arm muscle circumference has been found to have a higher prognostic power in predicting mortality among cirrhosis. So anthropometry, though it is simple, non-invasive and inexpensive, it is very good for large surveys and ideal for serial assessments. However, there are disadvantages like it has poor precision, especially in terms of patients with obese individuals, and it has high inter-observer variability. So we come to the first advanced method, which is one of the most practical methods for assessment of body composition, and that is bioelectrical impedance analysis. Now, the principle of BIA is based on the comparative resistance of the body tissue, that is also called as the impedance, to the flow of very small alternating current, which is less than 1 milliamperes, when it is passed through the body at one or multiple frequencies. Now, considering that muscle is a good conductor of electricity than fat, it estimates the total body water and thus reduces the fat mass and the fat-free mass. But in the more advanced versions or advanced machines of the bioelectrical impedance analysis, the body is modeled as 5 cylindrical compartments, and the trunk and the 4 limbs, Now, the impedance or the resistance to the flow of the current is assumed to be directly proportional to the height of these compartments and inversely proportional to the cross-sectional area of these compartments. Hence, the placement of the multiple electrodes allows a segmental body composition analysis of the extremities and the trunk separately. So for a more precise estimation of the body composition with BIA, what we ideally need is an 8-point tactile electrode system, multiple frequencies of the current, both at low and high frequencies. And for this enables a direct measurement of the body composition rather than a partial measurement and remaining the rest by estimations from the empirical data. Now, this is the classical output of the bioelectrical impedance analysis, which gives us the fat-free mass, the fat mass, the estimated muscle mass, the fat percentage, and the segmental distribution in the body, that is of both the muscle as the fat in the trunk and the limbs separately. Now, in cirrhosis, the trunk is the part which is most commonly affected by fluid retention in patients with cirrhotics. And therefore, the whole idea is to disregard the truncal mass. And therefore, we take the sum of the muscle mass of only the 4 limbs, that is called as the appendicular skeletal muscle mass. Now, this ASM is divided by the height in meters square, and we get an index that is called as an ASMI, or the appendicular skeletal muscle index, which is a very popular method to define sarcopenia, both in NAFLD as well as in cirrhosis. And there are cutoffs published in the literature which very well define sarcopenia using ASMI. Likewise, there are also cutoffs that are published in the literature for defining obesity using the total body fat percentage as assessed by BIA. Now, the BIA measured appendicular skeletal muscle mass, it shows very good correlation, high correlations with the DEXA measured ASM. And in cirrhotics, BIA is a reliable tool for the determination of body cell mass in cirrhotic patients, both with and without ascites. Sarcopenia, as assessed by BIA, is very closely associated with the post-transplant mortality in patients with cirrhosis. And therefore, the technique of bioelectrical impedance analysis is quite widely used in liver diseases. It has been used widely in NAFLD for the assessment of body fat percentage. However, it is very popular, more popular rather, for the assessment of the lower skeletal muscle mass or the appendicular skeletal muscle mass in patients with NAFLD and CLD both. So it is an inexpensive technique, safe, portable, very useful for long-term monitoring. However, the instrument measurements are sensitive to the hydration status. Some instrument predictions may be population specific, and it is not an ideal method, certainly, for the assessment of visceral fat. So coming to the second method, that is DEXA, or the dual energy X-ray absorptiometry. DEXA was originally developed to assess the bone mineral density. It divides the body into 3 compartments: the bone mineral content, the lean mass, and the fat mass. And it is considered as a gold standard for body composition assessment in clinical practice. Now, the principle of DEXA is based on the X-ray beam attenuation in proportion to the body composition. Now, there are 2 X-ray beams of different energies. The incident rays are attenuated and the transmitted photons are detected here in the detector, and they originate from here. And based on the pixels, a 2-dimensional image is developed. Now, this is the classical output of the DEXA machine. And so here it allows a total as well as a segmental or regional body composition, along with the trunk and the arms and the limbs. It also gives an idea of the android and the gynoid region. And so in the more advanced softwares and machines of DEXA, it is now possible even to estimate the visceral adipose tissue by DEXA. However, the classical output gives us the fat mass, the lean mass, and the bone mineral content. DEXA is used to validate the other methods such as anthropometry and BIA, hence it's a gold standard method. It has excellent repeatability with very low coefficient of variations. It has large availability, widely available in most of the hospitals, modest cost, it is very safe, and it is ideal for the obese patients because of the wide scanning space it provides. However, unfortunately, the fluid imbalances can change the X-ray passage, and ascites accumulation, especially for more than 4 liters, can impact the truncal measures of the muscle mass. Hence, the whole idea is to go for the ASMI, as I mentioned previously, disregarding the truncal measurements. And so the ASMI, as shown in this study, is as assessed by DEXA, is not influenced by ascites and lower limb edema. As you can see here, the pre-paracentesis and the post-paracentesis measurements of the ASMI is almost comparable. And so sarcopenia assessed this way does predict mortality in cirrhosis. There are cutoffs published in the literature for the DEXA-based ASMI, and they are very much similar to that of the BIA-based ASMI. And so DEXA is one of the very popular methods for assessing the appendicular lean mass or the fat-free mass index in patients with cirrhosis. And some studies have also used it in NAFL to assess the body fat percentage and also for the visceral adipose tissue in patients with NAFL. Now, coming to the third technique, and that is ultrasonography. Ultrasonography has also been used as one of the methods for assessing the body composition in patients. Now, the principle of ultrasound is based on the production of high-frequency sound waves. Now, these sound waves, when they pass through the skin surface, they reflect off the underlying anatomic structures, the skeletal muscles, and the bone surface interfaces. Now, the returning sound waves or the echoes, they are captured in the receiver, which is housed in the transducer probes. The commercial B-mode systems, they display a two-dimensional grayscale image that can be analyzed using specialized softwares. Now, this is a classical output of the ultrasonograph of the thigh ultrasound. Now, the black areas are the no echoes, whereas the whites are the strong reflections. Now, what we see here is the skin and the subcutaneous fat interface, the fat thickness, the fat and the muscle interface, the muscle thickness, and the muscle and the bone interface. And well, in this study, we see that high correlations were seen between the skeletal muscle thickness as assessed by ultrasonograph and the MRI measured skeletal muscle mass. So much so that an equation was developed to give us the total skeletal muscle mass of the individual from the image dimensions. And so, as far as the body composition by ultrasound is concerned, for muscle mass, it is, yes, an accurate, reproducible, and a fast technique. But for the adiposity, it is though easy and close at hand technique, but there are doubts regarding the validity, because there are some studies which tell us that ultrasound is not, the skin fold is far more better than ultrasound for subcutaneous adipose tissue, whereas the other studies that tell that ultrasound is the most powerful identifier of visceral adipose tissue. However, in the lack of the standardized protocols, there is a decrease in the accuracy and reliability of ultrasound regarding the body composition measurement, especially the visceral adiposity. So though ultrasound is something which is becoming popular, especially for the individual group of muscles, it is a easy bedside method, very popular for the critically ill patients. It's a non-invasive and fast method and ideal for longitudinal monitoring. However, technical skills are required. We have to take care that the muscles have to be in the relaxed state, and obesity may sometimes lead to underestimation of the muscle mass. Well, Tandon et al. In this study, they have assessed the thigh muscle thickness of almost 160 patients with cirrhosis. And what they did was they took an average of the compression and the featherweight reading and corrected it for the stature, and concluded that in patients with cirrhosis, a combination of the body mass index and the thigh muscle thickness can identify patients with sarcopenia almost as well as the cross-sectional imaging. And so the technique of ultrasound is used in some of the studies to assess the visceral and the subcutaneous fat in patients with NAFL. However, we find only one study which has been recently published, which assesses the psoas muscle diameter in cirrhosis. And few studies have recently come up only in this form of abstracts and posters, which assess the quadricep muscle layer thickness using the technique of ultrasound. Now, coming to the last and the most advanced method of assessing body composition, and that is CT, or the computerized tomography. Now, CT is the direct method for the assessment of body compositions, and it is considered as the gold standard method, particularly when it comes to quantification of the muscle mass. It's a very precise and an accurate method of assessment. Now, the principle of CT is based on a large number of X-ray projections of the body from different angles. Now, based on the known differences in attenuation of the X-rays, which is quantified in terms of the Hounsfield units, which is HU, the lean and the adipose tissue are identified. Now, the CT, though, has the potential to give the direct volumetric assessments from a high-resolution 3D images. Most of the CT-based body composition analysis is done only on a 2D analysis of one or limited number of axial slices of the body. Now here, the area, mind you, is taken as a measure which is used as a proxy for the volume assessment. Now, a single slice CT image is analyzed using special softwares. These softwares could be the Slice-O-Matic or the MATLAB, whichever. The automated sometimes, and they are semi-automated. And so, as you can see in this image, the cross-sectional areas of almost 6 to 7 muscles, they are analyzed first at the L3 and L4 region, and using the predefined Hounsfield unit intensities, and then the subcutaneous fat as well as the visceral fat. Subcutaneous fat in blue and visceral fat in yellow, they are identified as the SAT and the VAT, SAT and the VAT. And the muscularity in this case is expressed in terms of the skeletal muscle index, whereas in this case, the mass, which was in kgs previously, is now replaced by area, which is divided by the height in meters square. Now, the CT-based assessments are, especially for the muscle mass, they are based on certain assumptions. And these assumptions are that the muscle area determined from a single slice abdominal scan obtained by a CT is highly correlated with total body skeletal muscle mass quantified by the whole body multi-slice analysis, and this is done from cadaveric studies. And the second is that in order to improve the simplicity, applicability, and the daily practice, rather than assessing the muscle area of all the muscles, only the area of the psoas muscle is analyzed and can be used beautifully for the assessment of sarcopenia and muscle deprivation in these patients. So likewise, now the cutoffs are also available. A large number of cutoffs are available for defining both the muscularity as well as the adiposity based on the CT-based assessments. Like there are European cutoffs, which are done by Montano-Loza, very popular, and by Fujiwara, which are the Asian cutoffs. And these are both the mortality-associated cutoffs, which are used. We at our department and our student, we did find out the normative cutoffs using the healthy controls, and these are all used to define sarcopenia using the skeletal muscle index. Likewise, there are also cutoffs, both Japanese as well as Korean cutoffs available in the literature for defining the visceral adiposity and the subcutaneous adiposity in patients. In this slide, you can very beautifully observe the decrease in not only the thickness of the skeletal muscle mass, the skeletal muscle area, but also the subcutaneous fat across all the child A, B, and C cirrhosis in comparison to the healthy controls. And this is when these controls and the patients, they are at the same age and the same BMI. So the CT has been identified. It has the potential to identify the highest percentage of patients with sarcopenia and cirrhosis. And this study tells us that no other technique can actually replace the CT measurements. And they say that it assesses almost 76% of patients with sarcopenia in comparison to MAMC, that is the anthropometry, and the DEXA-based ASMI. And so this slide shows us that there are a plethora of studies that have used the technique of CT for the assessment of body composition, particularly for the assessment of skeletal muscle mass. As you can see that all of these, they use the SMI, and defining the sarcopenia, and the prevalence of sarcopenia ranges anywhere between 30% to 70% in these patients with cirrhosis. So CT is a technique which has very high precision and accuracy. And unlike the other methods, it is routinely performed for all the patients with liver disease. However, it has the disadvantage, it exposes the patients to the high ionizing radiations, and there could be a few minor errors in patient positioning, slide selection, and more than that, the image interpretation. Hence, in the end, I would like to sum up that as the simplicity, applicability, and practicality of the methods increases, the precision and the accuracy certainly decreases. Anthropometric techniques are very widely used in cirrhosis, but they show poor precision, particularly in the obese individuals. Direct estimations by a multi-frequency bioelectrical impedance analysis, they are ideal for the body composition using the BIA technique. DEXA is very popular in the liver disease for estimations of muscle mass using the technique of ASMI. Ultrasound is a good technique for the individual muscle group estimations, particularly in the critically ill patients where it is very widely used. However, it warrants more research in cirrhosis and other liver diseases. And CT is well studied in cirrhosis and ideal for body composition analysis, both for muscle and the fat. Thank you.
Thank you very much, Professor Benjamin, for your excellent talk. I think this is the APASL e-learning seminar, just targeted not only for the specialists, but also the practitioners and also medical students even. And, you know, formerly we believe that it's very important restrict of the intake of the protein in order to prevent the hepatic encephalopathy. But recent 20 years now, we never restrict the protein intake. And I would like to ask you about how much gram per day protein these people would like to take a protein in order to prevent the sarcopenia.
Thank you, Professor Kardir. Am I audible?
Yes.
Can you hear me? Okay.
Yes, I hear.
Thank you, sir. Thank you, sir. As far as your question is concerned, initially I agree that from the books of standard books of hepatology from Sheila Sherlock, where protein restriction was advised. But we have come a long way since then, and we have realized especially through the very landmark study by Cordoba et al. In 2004, which has actually changed the way we look at protein restriction in liver disease. And since then, the guidelines, both the 2006, 2009, and the recent 2019 and 20 guidelines, they all recommend that we give these patients with cirrhosis protein in the order of 1.2 to 1.5 grams per kg body weight, and at least not below that. But in critically ill cirrhotics, we may go even up to 2 and 2.5 grams if they are severely sarcopenic, malnourished, and particularly if they are undergoing certain therapies like the renal replacement therapies. So in no ways protein is restricted for these patients, and for anabolism, say for the OPD patients, 1.2 to 1.5 is an ideal and very easily manageable amount that can be given to these patients.
Okay. Also, I would like to know, is there any role of MR for the body composition assessment?
Yes, sir. In many, though we don't do it at our institute, and we haven't, we don't have any first-hand experience on that. But yes, the MRI is much more advanced than the CT or the computerized tomography. First of all, now but its use is limited because of its because it's very costly. It's much more costlier than the CT. But it's better in a way because it doesn't subject the patient to the ionizing radiations. But the problem with the CT volumetry, it gives us the volume in meter cube, and we need high specialized softwares for the analysis. So it is much more an advanced version than the CT. And I think for a very good accuracy, we should settle for CT. But yes, MRI has got for a much precise volumetric assessment, CT is, an MRI would be an ideal technique.
There are two questions from audience. The first one, is there any specific probe for ultrasound for measuring adiposity?
For adiposity?
Yes.
I'm afraid, sir, I won't be able to answer that. But yes, for this, I can answer in a way that the studies that I have mentioned in my presentation, where the technique of ultrasonograph was used for the assessment of body composition, they have used the monocrystalline high frequency abdominal probes. And so that is what I can tell you. So the monocrystalline high frequency abdominal probes. But this answer would be more precisely, question would be more precisely answered by a radiologist rather than a nutritionist.
The second question, which of the two adipose tissue or muscle mass is important for both that predicts poor outcome in transplanted listed patients?
Sorry, sir, I didn't get the question.
Which of the two adipose tissue or muscle mass is important that predicts poor outcome in transplanted?
Oh, certainly it is the poor muscle mass which predicts a poor outcome of transplantation, because obesity has got contradictory results. As a transplant outcome, if you look at the obese patients, they rather fare well in few studies. However, in a different set of analysis and a different set of studies which tell us that obese patients, they don't do so well. But there is a controversy regarding obesity, but undoubtedly the poor muscle mass is certainly a poor predictor of transplant outcome. And the reasons could be that once the BMI increases, the muscle mass also increases. So that way the muscle could be a protective factor, and that's why it never comes out very clearly if you take only BMI. So when you take the muscle mass in terms of sarcopenia or the SMI, then it certainly does come out as a poor predictor of survival, and it's in post-transplant patients.
Two questions came recently. Yeah, two questions. Do you have time, Professor Tamwande?
Yes,
yes,
sir.
The question is, any free software to calculate SMI in CT scan?
Yeah, there are two softwares. The software that we use at our institute is called the Sliceometric software. And that's an automated, semi-automated software, and there are fully automated softwares also available, and that's called the MATLAB software.
The last question is the cutoff value for sarcopenia in Indian population?
Oh, it is 36 for men and 30 for women.
Thank you very much, Professor Benjamin. And now, Professor Diana, please.
Oh, yes. Thank you very much, Professor. Our next speaker is wait, let me just get police records. Okay. He's an associate professor of medicine and a co-director of cirrhosis care clinic and transplant pathology at the University of Alberta in Edmonton, Canada. Her clinical practice and research are focused on cirrhosis with research interests, including cirrhosis-related complications, malnutrition, frailty, exercise therapy, palliative care, integrative health approaches. And therefore, her career goal is to provide holistic, interdisciplinary, evidence-based, patient-centered care through education and empowerment. Oh, this is interesting. To give us two talks actually on nutrition and liver diseases is Dr. Puneeta Tandon. She will talk on functional assessment methods for detailed nutritional assessment in liver diseases. And lastly, how to write the nutrition and exercise prescription for liver disease patients. Professor Tandon.
Thank you so much for that introduction. Let me just share my screen. And There we go. Everyone can see, hopefully. Thank you so much to the organizers for this invitation. It's my absolute honor to be here today. And so, yes, I've been asked to give 2 talks, one around functional assessment, and then we'll go into therapy. Okay, these are my disclosures. And before we start, I just want us to do a self-assessment. And so from 0 to 10, just want you to think about how confident you feel that when you see your next cirrhosis patient in clinic, you're going to be able to determine if they are frail using a validated tool. So just think about that from 0 to 10. How confident do you feel? How confident do you feel that as a non-dietitian, you can provide them with some basic nutrition advice and advice around nutrition resources, information about how much protein they need to take in? And then thirdly, provide them with some basic exercise advice. So exercise resources, how hard they should be working out, again, as a non-exercise specialist. And my aims then in the next 40 minutes are to shift you closer to a 10 on those answers and to really convince you that functional testing and nutrition and exercise therapy are absolutely essential. And this is really all to try and close this knowledge to action gap. So we can do lots and lots of research looking at all the intricacies of everything, but if we can't actually get that into practice, then we're losing a lot in the gap. Now, you've heard beautiful talks from my colleagues, and they've discussed malnutrition, they've discussed sarcopenia and body composition, and I'm going to be talking about physical frailty. And just to ground us in the fact that all of these are very interrelated concepts, and I would say that they're very connected by the objective measurement of muscle and muscle health. And because they're interconnected, it's reasonable to consider that these concepts also share many of the same pathophysiological drivers. And so this was a very nice article by Sinclair et al. That summarized this for sarcopenia, but I would say probably these are similar in the other conditions. Things like reduced oral intake, as we've heard about, malabsorption, inflammation, hypogonadism, elevated serum ammonia, which we know is myotoxic, and then physical inactivity. So Dr. Raman's already touched on this. Why do we need to translate this urgently into practice? These are so common as far as complications of cirrhosis, and they're often unrecognized. They independently influence mortality and morbidity. So morbidity-wise, we're looking at these patients coming into hospital more, being admitted to the intensive care unit more and staying longer in hospital, having an increased risk of infections, that connection with hepatic encephalopathy, and then increased costs of care. And importantly, these things are potentially modifiable. So let's meet a patient. Let's go to our clinic and meet Mr. QT. He's a 52-year-old male. He's got cirrhosis related to alcohol, and he's obese, so his BMI is 32. He has liver-related complications. He's got moderate ascites. He's on diuretic therapy. He's got hepatic encephalopathy that's controlled on lactulose, and he's a child Q-B8 with a MELD score of 17. He's listed for liver transplant. And what if I tell you that he looks like this? So he's tired, but he can walk a flight of stairs, and he's independent for all of his activities of daily living. What instead if I tell you that he looks like this? So this gentleman has got a walker after 2 falls, and he needs help for his housework and for other things like shopping for food. And so what is that concept that we all capture? And that concept is frailty. So frailty means low physiologic reserve, and that leads to this vulnerability to stressors. And I love this figure from an aging guideline, where they go into the different categories. So if you look at robust patients, like hopefully most of us, those patients will have a stressor and they will recover back up to normal. A pre-frail patient will have a stressor like an infection, for example, or a variceal bleed, and they will recover but not quite back up to normal. And then look at our frail patients. So our frail patients are sitting in what my friend Jen Lai likes to call this zone of adverse outcomes. So they have a stressor and they drop into the zone of adverse outcomes where they fall into dependency and disability. And it's so, so important that we get to all of our patients, even when they're pre-frail. So in the next few minutes, I'm going to talk to you about 3 steps. And I'm trying to keep these very, very practical just so that we can implement some of this into our clinics. The first is to assess, and obviously once you learn to assess, then to reassess frailty, to see how it's changing with your therapies or to see how it's changing with their disease progression, to initiate a very basic nutrition intervention and advice for your patients, and again, to initiate an exercise intervention. So things that I hope you can take into your practice as soon as you get back into clinic next week. All right, so let's start with step 1. So there is a frailty toolbox of tools that have been evaluated in patients with cirrhosis, and this is a big toolbox. It includes things like the Freed Frailty Index, the LFI or Liver Frailty Index I'll talk to you about. This was brought up by one of the professors earlier, the Short Physical Performance Battery, survey-based tools, which I'll touch on, Karnofsky and Clinical Frailty Scale, and then single measures like gait speed, 6-minute walk speed, which was also touched on, and then something more complex, but very good as well, cardiopulmonary exercise testing. So all of these have been evaluated in cirrhosis. Now, as a clinician, how do you decide which test to use? And it really depends. It depends on your purpose. So are you doing it for clinical? Are you doing it for research? It depends upon your setting. Are you in an inpatient setting, an outpatient setting, a critical care setting, and your access to tools? So if you're looking at something that's very easy to use and a screen, then I'll talk to you about the Clinical Frailty Scale and Karnofsky Performance Scale. We're all familiar with the activities of daily living, which has also been associated with impaired outcome. If you're looking for something that's very objective and that you can repeat over time and see changes over time, then I'll talk to you about the Liver Frailty Index and other tools like the 6-minute walk test and this CPET or VO2 testing. And if you want something in between, then these single measures like 4-meter gait speed and hand grip strength have also been very valuable. So again, really depends on a lot of things as to what you choose, but know that you have a big toolkit to choose from. And this mixes in very nicely with Dr. Benjamin's tools around sarcopenia and assessment of muscle mass. Okay, so the 2 tools that I've chosen to select for easy to use and screens are the Clinical Frailty Scale on the left. And this scale, as you can see, it takes about 30 seconds or to a minute to really determine where someone would fit on this scale. It gives you very nice descriptions ranging from very fit, going down to vulnerable, which we would call pre-frail, and then going down to the frail population. Case of people who are slower, they need help in their activities of daily living. And it predicts, as I'll show you on the next slide, mortality and hospitalization. We've also done work, as have other groups, in the Karnofsky Performance Scale, which is sometimes routinely measured at many centers. And this again is a performance metric that is subjective, dividing patients into low, intermediate, and high, but again, very predictive of mortality. So very simple tools, easy to use. Clinical Frailty Scale, when we looked at it in our population, this was 300 patients. 18% of patients scored as frail, so a score of greater than 4, and 33% were pre-frail. But there was a dose response. So for every unit increase in the Clinical Frailty Scale, the adjusted odds of hospitalization were almost 2-fold. And importantly, the Clinical Frailty Scale, we compared it to tools like the Short Physical Performance Battery and the Freed, and it had comparable discrimination to actually diagnosing hospitalization and death risk. Okay, in between tools, and this was already mentioned, hand grip strength. There are studies to support this. This is one of the more recent ones. Hand grip strength, I think, is a very valuable tool as long as you have the equipment present in the clinic, and as long as the patient can obviously cooperate with the measurement. And so this was a study of 145 male patients, again by Sinclair, and they did 3 different muscle measures. They did hand grip strength, where they defined hand grip strength abnormal as less than 30 kilograms. They did DEXA, and they did a single slice CT scan at L4. They looked at the prediction of mortality, and they found that a MELD hand grip model was actually superior over all of the other models. And they again found a dose response, so 6% mortality reduction for every kilo increase in strength. Gait speed is also one of these single measures that's quicker, and it doesn't require any real equipment. This has been studied a lot by Mike Dunn, and what Mike has found is that gait speed in meters per second is associated with hospitalization, so number of hospital days per year, and he's correlated that into costs, which is very nice to sort of see how this directly affects the system. In a recent study, he has also looked at the prediction of post-transplant outcomes using gait speed and found that it, as compared to other measures, including the skeletal muscle index, showed the strongest association with post-transplant respiratory infection. Very good test, again, and done in many UK centers for patients who are undergoing transplant assessment, is cardiopulmonary exercise testing. And we performed a systematic review of 7 of these studies looking at over 1,000 patients. And you can see that the baseline cardiopulmonary exercise testing of patients showed a VO2 of only 17.4. So to put this into context, although these patients were mean age of in their 50s and 60s, this made them look, when you looked at them physiologically, they looked like sedentary 80-year-old females. And VO2 was very, very robust in predicting mortality pre-transplant, as well as it was an independent predictor of post-transplant outcomes such as death, hospitalization, and length of stay. So excellent marker, takes special equipment, takes about an hour to do one of these tests. 6-minute walk test is a submaximal test of endurance rather. And so it is also very useful. And our physiotherapists who do this say that it really helps just to watch the patient and how they're moving over that time of 6 minutes. So what their balance is like. You get a lot of tips just from doing the test itself, in addition to obviously the walk distance. So this has been popularized by Carey et al. And then independently studied in a few other studies. And essentially you just record the distance traveled over 6 minutes. One study shows that it again may be more predictive of weightless mortality than sarcopenia. And the predictive cutoff to date has been 250 meters, although in our group, we've just done some work with this and that seems a bit low. So there likely is, again, a dose response to this as opposed to a firm cutoff. This tool I love, and this was popularized by Jennifer Lai out of California. And it's similar to the short physical performance battery that was raised. So 3 tests: grip strength, like we've talked about, chair stands. So this is where you're getting your patient to see how long it takes them to do 5 chair stands, and you give them up to 60 seconds. And then 3 balance tests, which you measure how are they able to balance in each of these postures for 10 seconds each. And all of this is scored, and the scoring system is available on the Liver Frailty Index website. This is simple to do, it's objective, and it's continuous. It takes about 90 seconds to do it, and there have been a lot of data published from Jen's site showing that it's reproducible and reliable. So frailty by the Liver Frailty Index, again, is independent of the MELD. So all of these tools are independent of liver disease severity. And what they've shown very nicely is that it adds about 9 points to your MELD score to be frail by the Liver Frailty Index. A recent study, which I also like very much, looked at patients. So imagine your patient who has no ascites and no hepatic encephalopathy, thinking of that very standard group. What happens if they're frail versus not frail on mortality? And you can see that when they broke it up by these things, so ascites, hepatic encephalopathy, or both ascites and hepatic encephalopathy, the frail patients always died more, okay, no matter if they had those similar complications. And she's just recently published that changes in frailty are associated with waitlist mortality as well, which makes sense. So progressive measures over time give us information. If your liver frailty index is improving, the patient is going to improve. If your liver frailty index is getting worse, your patient is going to do worse. And this, I think, applies to other tools as well, although we have less evidence to support that. Now, this concludes the first step, but I do want to raise a caution, and Dr. Benjamin raised this very nicely with sarcopenia, that there are likely different cutoffs for Asian populations versus for North American populations. And so this was brought up in a frailty guideline that was published in 2017, where they suggested, for example, for grip strength, that Asian populations, Taiwanese older adults in this case, had a 25% lower grip strength. And so it suggested that Asian populations have a different cutoff for this. This has not been well explored yet, and I think this is an area that I would encourage research, is what are the cutoffs for these frailty metrics in Asia. Okay, so step 2. Now, as non-dietitians, how do we give our patient a nutrition prescription or a nutrition intervention? And so this is not going to be very complicated stuff, but I want you to remember it in clinic to be able to at least provide these basic bits of information. First off, every patient deserves education. And like I showed you, we need to get at those patients, no problem even if we get at them when they're robust, but definitely when they're pre-frail, and certainly when they're frail. Basic nutrition prescription, and then booking an assessment with a dietitian, as Dr. Raman appropriately pointed out. This is a team game. So I don't have a lot of time to show you the different studies that have reported the benefits of nutrition in this population, and there's certainly some controversial evidence looking at some of the intensive care unit studies or hospitalized studies that haven't shown benefit, but have included very, very sick patients for the most part. So this is one study from India that I'm going to highlight. And this is a randomized control trial, simple intervention, nutrition education by a dietitian with monthly reinforcement versus standard of care. Intervention given for 6 months. These were sick patients, MELD score of 17. Half of them had alcohol-related liver disease. And these are the guideline recommendations. So you will be familiar with the caloric intake, as was already mentioned, 30 to 35 kilocalories per kilogram. Protein intake of generally 1.2 to 1.5 grams per kilogram per day. And then 2 grams sodium diet if necessary for fluid overload. And what they found by doing this for 6 months is that there was reversal of minimal hepatic encephalopathy in 71% versus 23%. And this makes sense, as you know, the connection between muscle. So as the liver loses its ability to detoxify ammonia, the muscle really takes over as that secondary site of ammonia detoxification. So if we can improve our muscle, we can reduce our hepatic encephalopathy. There was also significant improvement in quality of life, muscle mass and strength, and a significant reduction in hospitalizations. Second study I'm going to show you is an inpatient study, and this was also around education. And so this was done by Jaz Bajaj and his group, and what they did is they provided education to physicians and education to the nurses around nutritional assessment and importance of adequate nutrition in hospital. And what they found was that days of inadequate nutrition reduced, dietitian consultation very appropriately increased. I believe every cirrhotic patient who comes into hospital should see a dietitian. Unfortunately, we have a shortage of dietitians, but I think that would help care a lot. Modest increase in nighttime snack, as we'll talk about later. But look at this, length of stay decreased, as did 90-day readmission rates. So with nutrition, how can you make a change in your practice? And this applies to exercise as well, this next slide. This was something that Jen Lai and I put together around behavior change and the importance of this in patients where you're trying to, where you're trying to get them to do a lifestyle intervention. So unfortunately, it's not just enough to give them information. You do need to give them some information alongside behavioral skills. And so practical ways to use the information that you're giving them. And ideally, if you have a chance to really assess in some way their motivation for doing this, what's driving them to want to get stronger, and trying to help them build that vision together with them. So I'll refer you to that article that we wrote in American Journal, but this whole aspect of motivational interviewing and really bringing out that value for the patient is something that I think we all need to also get better at as physicians. So with regards to education, this is our nutrition and cirrhosis guide, which I about previously, and this is found on a www.wellnesstoolbox.ca. And what this is a 40-page guide that really has a lot of pictures and puts it into plain patient language as to the importance of malnutrition and the importance of different treatments. And this is being translated into different languages, including into Hindi. And I would love to work with anybody who's interested into translating it into additional languages for your particular countries. So every patient, give them education. Secondly, thinking about, like Dr. Raman pointed out with her nutrition screening tools, does Mr. QT need a referral to a dietitian? And so automatic dietitian referral, absolutely in the highest risk patients, always. So BMI of less than 18.5, or your very sick patient's child QC, or I would say anyone who has any of these conditions that you've picked up needs to see a dietitian. You can also use the nutrition screening tools that Dr. Raman's pointed out to determine who then needs assessment and referral. I want to leave you with 4 basic nutrition interventions that I want you to think about in your clinic. So number 1, addressing intake and barriers to intake. Number 2, we recommend limiting sodium intake, which is very important in our patients with fluid overload, but thinking about what that comes with. Frequent meals and snacks, and then providing a protein intake target. We've talked about the caloric intake target. I won't go into that too much because again, as non-dietitians, I think that is more in the realm of a dietitian to exactly go through how many calories you need, how much, how you can spread that out over your day and change your diet accordingly. All right, so basic practical questions to assess dietary intake that you can do in your clinic. One thing is to ask about nutritional inadequacies. And so that would just be a simple question about how often do you eat in a day? And you will find that many of your patients will tell you that they eat only once a day. That tells you a lot, and that's a lot that you can just start to work with to change. Asking about whether or not they take in protein with most of their meals. And so meat or eggs or fish or dairy protein. And importantly, what stops them from eating? So these 3 questions are very important to get a practical way to try and change what's going on in that patient's life. As Dr. Raman brought up, social factors are so important in this population. Can they afford food? Do they even know how to cook? Are they strong enough to cook? So those things will make a big difference. And some very basic tips that I've learned from our dietitians. Number 1, consult them because they have this expertise. Number 2, you can give them tips. So these patients will feel full faster, especially if they have ascites. So managing those kind of things, managing their ascites, obviously. Recommending simple things like grazing, frequent meals, small meals, but often. Not drinking a bunch of fluid at the same time as you're going to eat. Nutrient-dense food, so these supplements that we can provide. This is liquid nutrition, and oftentimes these patients will need it as they get sicker. many patients will feel anorexic, and so seeing food as a drug and recognizing that cold foods may cause less aversion than hot foods just because of the aroma. We starve our patients when they come to medical appointments, and we starve them when they're in hospital. So advising patients around this and addressing your NPO policies. So what we've done at our hospital, they used to starve patients for paracentesis. Now we no longer do that. So trying to really change these things at your hospitals, and then getting social work involved for food security. Okay, secondly, moderate sodium restriction is recommended in patients with volume overload, and so we generally recommend a 2-gram sodium diet. This was a nice study in 120 Italian patients where they counseled patients on a low sodium diet. And look at this, only a third were actually adherent to a 2-gram sodium diet. And adherent patients had a 20% lower daily caloric intake. So we have to be careful of this, that we do also get our patients to see a dietitian around increasing the palatability of their food when we are recommending sodium restriction. Dr. Raman mentioned that our patients live in this state of accelerated starvation. So as the next topic, I'm going to recommend that we remember snacking and frequent meals. So what happens, obviously, is that the patients reduce their ability to store glycogen, and that leads to muscle breakdown because you're pulling glucose from proteolysis from muscle. Our patients who fast for overnight fast look like we would fast metabolically after 3 days of starvation. So this is a very serious problem. And this is a landmark study by Planck that shows us that the timing of nutritional intake is essential. So this was 103 patients, and they had an isocaloric intervention. So they had 710 calories given either in the evening time or in the daytime. Then the evening or late evening time was 9 p.m. to 7 a.m. So isocaloric, same amount of calories, but what they found is that the evening supplementation was associated with a significant improvement in muscle mass and an increase in health-related quality of life. And I just want to show you the figure on the right. Look at this. It was the total body protein change was across the child Q classes. Okay, so it works in patients, and there have been other studies supporting a reduction in the frequency and severity of hepatic encephalopathy with these late evening snacks. So a very important tip then, number 3, is frequent meals and snacks. What I've learned from my dietitians is to get your patients to set an alarm on their phone or on their watch to eat every 4 hours while they're awake. I don't necessarily get my patients to wake up at night to eat because sleep is also very important. But if they are getting up to go to the bathroom or they can eat, then certainly that is appropriate as well. And in countries where you eat very late, then breakfast, an early breakfast or breaking that fast is important. The snacks, there have been a variety of different composition of these, but in general, if it consists of complex carbohydrates and protein, that's appropriate. Okay, the last piece I want to focus on is protein, and a couple of studies just to support the importance of this. So this was some work that we did in our patients awaiting liver transplantation, 630 patients. And we learned 2 important things. One was that very few of our patients actually met protein intake targets. So only 24% of these patients did take in more than 1.2 grams per kilo per day. But the second important thing that we learned was look at this Kaplan-Meier with cumulative incidence of death. And you can see adjusted for other prognostic factors like age, like MELD score, etc. Low protein intake, less than 0.8 grams per kilogram per day, was independently predictive of mortality. And this is so important because it's modifiable. This was brought up by Dr. Benjamin, and it is a landmark study that really changed our thinking about protein. Unfortunately, I still see consults and referrals where people are restricting protein in these patients. This is not necessary. And so this study, what they did is they randomized patients with cirrhosis and hepatic encephalopathy to a low protein diet versus 1.2 grams per kilo per day. no difference in the course of their hepatic encephalopathy, but they did find that the patients on the restricted diet increased the amount of muscle breakdown that they had, even in that short time. There's weak evidence, but I find it interesting, and I think this will be a very interesting area for future study, that vegetable proteins may have some advantages. So that means, you know, beans, peas, lentils, tofu, and studies, very weak studies, have shown that these increase dietary fiber and that prebiotic property might alter the microbiome and then reduce hepatic encephalopathy producing compounds. And so the guidelines have recognized this in that they're now encouraging the consumption of veggie and dairy proteins. This by no means means to cut out meat, but it means to encourage a variety of protein intake. And so this is your fourth tip, is really encouraging protein from a variety of sources, again, aiming for that 1.2 to 1.5 grams per kilogram per day. Also on the Wellness Toolbox site, because again, it was difficult for me to know how to calculate all these things with ideal body weight. So we created this nutrition prescription calculator, and it gives you caloric intake as well as what the protein intake would be for a patient. And it's on the Wellness Toolbox site. The handouts that are also on that site have protein intake and very nice graphics for patients about what amount of protein they can take in different kinds of food. So again, all patients should have this information. Now, Dr. Raman brought this up, sarcopenic obesity, and we need to treat these patients differently. So there are some patients where they're on the transplant list and they do need to lose some weight in some of our patients. What do we need to do differently? We need to recognize that when you're losing weight, you're also losing muscle. And so in that patient population, dietitian involvement is even more important. Need to avoid low calorie or fad diets. Again, same principles of protein at every meal, frequent meals and snacks, optimizing the diet quality. So limiting, for example, saturated fats. And it needs to be combined with exercise. Okay, that is where in the studies you are going to reduce that impact on muscle loss. Our poor Mr. QT gets admitted to hospital with hepatic encephalopathy. So I'll just go into this very briefly, but we know that muscle loss accelerates in hospital because patients are sedentary. There haven't been studies in cirrhosis that I'm aware of to date. This was critically ill patients. Look at what happens to their muscle over 10 days, almost a 20% loss in cross-sectional area by ultrasound, as Jaya was describing to us. And so very, very important that we maintain that 35 to 40 kilocalories per kilogram body weight, or 1.3 times their measured resting energy expenditure. And that indirect calorimetry does become more important, especially in hospitalized patients. And that we promptly move to enteral, or if necessary, parenteral nutrition in people who are unable to maintain that intake. Just on a practical note, what we have been trying to do at our site is trying to make this into an electronic order set. And electronic order sets may or may not be available, but again, education, like Jaz Bajaj pointed out, very important for routine malnutrition screening and early dietitian referral. I've been trying to educate our residents to say, don't order a 2-gram sodium diet, order a high protein, high calorie 2-gram sodium diet. So in that way, patients will get additional protein and snacks. And then we give all of our patients discharge education around nutrition. Okay, so stepping away from nutrition, let's go into exercise. And exercise is also very, very important. And again, I'm coming at this as a non-exercise professional. We can still give our patients some advice. So 3 things that we're going to do. But first, let me tell you why it's so important. In addition to what I've talked about, is that there again is a major gap. Our patients have the lowest activity levels amongst many patients with chronic disease. 76% of their time, if you monitor them, is sedentary. Now, there have been studies of exercise, and there's more coming out. Sample sizes thus far have been small. Most of them have been in earlier patients with cirrhosis, and the duration up to 16 weeks. The majority have been supervised and the majority have been aerobic, although there are studies now coming out with combining aerobic and resistance training. Importantly, it has worked. So that VO2 testing that I talked to you about, we did a study, a couple of studies looking at exercise in this group, and you can shift patients from being 80-year-olds to being 70-year-olds within 3 months. So you change their physiology, okay? You can increase their muscle mass, you increase their quality of life, you increase their 6-minute walk test distance, and in the chronic phase, not acutely, chronically over the 3-month period, you can reduce their portal pressure in 2 studies. So first thing we need to do as physicians is assess the safety to exercise, and specific to cirrhosis, there is an increased chance of increasing portal pressure if they don't have appropriate prophylaxis. And so if they need primary or secondary prophylaxis, have them on beta blockers. Secondly, thinking about the fact that these patients are fragile and frail, and so caregivers may need to be present, especially if they have balance issues or they have hepatic encephalopathy. Secondly, thinking like an exercise professional, we can think about what recommendations we should give our patients, and it really strengthens, I think, when patients go to see a dietitian or see an exercise professional, if we as physicians can give them some basic guidance as well, it adds some more strength to those recommendations. So exercise professionals will divide these exercise prescriptions into frequency of exercise, intensity, time, and type. And we're going to go into that in a sec. So 2 things, aerobic and resistance training. You're asking your patients to do some sort of aerobic activity 3 to 5 days a week, and some sort of resistance training 2 days a week at least. So aerobic conditioning, just getting your patients to start with walking, even 10 minutes a day, and progressing by a minute a day to a goal of 30 minutes of continuous activity. We recommend using the talk test to guide intensity. And so that means you want them to still be able to talk, but short of breath. Okay, so slightly short of breath, able to talk. Obviously, if they are at risk of falling, use a gait aid, but that should not stop them from walking. And we then again want them to get to that 150 minutes around per week. Resistance training can be done without equipment or with equipment. And so you can use weights or bands or body weight, and you can do functional strength testing. So I will just tell my patients about the sit to stand exercises, which are like the chair stands. Climbing and overhead reaching, there's very many exercises that you can do. Often we recommend low weights, high repetitions in these patients. And again, I'm not an exercise specialist, but I do give my patients handouts. And I give my patients handouts for some of these activities. And I think it's very useful to not only just say to the patient, like that behavioral slide that I showed you, not only give them the information, but give them the behavioral skills that they need to do these things. So handouts, very useful. And again, I point you to the wellnesstoolbox.ca, which has exercise videos for patients. These are at different levels of intensity. Okay, so I'm going to summarize by saying that the 3 talks that you've heard have really given you, I would say, a toolkit of screening and assessment tools for patients with cirrhosis. And now it's up to you to try and think about, depending upon whether you're using it for research or clinical or inpatients or outpatients, and what your unique clinical context is, obviously, and what you have available. You have a huge number of tools that you can potentially draw from to use. And just doing the screening is not enough. Okay, we need to move to some basic steps for all of our patients. And again, the main messages that I've showed you about nutrition and about exercise, those need to be tailored to your clinical context and to your cultural context as well, which you will understand best. Now I want to just take you back to this. So I hope that you've been able to now gain some confidence, and over the 3 talks of feeling like you can now pick out a tool to determine if your patient is frail, even as something as the clinical frailty scale, to provide them with basic nutrition advice, asking them about barriers, telling them about timing of intake and how important that is, talking to them about protein and giving them grams of protein, and recognizing that low salt diets can sometimes reduce intake, providing them with some basic exercise advice as well, and that there are resources available to do so. Many collaborators to acknowledge, and I'll leave my email up there, and happy to get any email questions as well. Thank you so much for the opportunity.
Thank you, Professor Tandon. It was definitely an enlightening and useful lecture for us. In the interest of time, we probably will just give 1 or 2 questions. One of the questions in the chat back is that you gave us a level of the protein, but is there a max level for the protein intake of patients, especially if the patient has AKI or CKD?
Yeah, so I think acute kidney injury obviously is where we do need to be a little bit careful about protein intake, but we want to use what our dietitians do, and again, maybe Maitreyi and Jaya can add it to this, is they use the ideal body weight when the patient is obese, because you don't also want to do the protein as far as the overall composition of the diet. As Jaya pointed out, in the critically ill, we do increase that level up, even up to 1.8 or 2 grams per kilo. But in general, it would be around that 1.2 to 1.5, using the ideal body weight when the BMI gets to that obese category.
Okay. What about the use of, if your patient cannot take so much protein, what about the use of supplemental protein? Like there are supplemental proteins like branched-chain amino acids that come up. And do you give this supplemental proteins at night because they have starvation at night, accelerated starvation when they sleep? So is that a practice that you do also in your clinics?
Yeah, great question. And so branched-chain amino acids is obviously one of the things I think that is quite different in different parts of the world, but there is evidence to support it, and evidence in the guidelines that would suggest 0.25 grams per kilo per day of branched-chain amino acids if your patients are unable to get in, like you said, enough dietary protein from foods.
So in that scenario, Professor, like the branched-chain amino acids that's given is quite expensive. So some people would supplement it with whey protein. Do you have experience on whey protein as a supplement for these patients?
I think that's very practical. Yeah, whey protein or protein shakes, those are all different ways of getting in protein for sure. And as you mentioned, giving that in the evening time, as was done in the Planck study, his study used Ensure, two bottles of Ensure that were given. So again, that showed quite a bit of benefit, 2 kilograms of muscle mass gain over that period of time of the study.
Okay, I think there are no more questions in the chat box. As everybody noticed, Professor Tandon was kind enough to give us her email. So if you have any questions, you can probably email her for some additional tips. I think I've learned a lot. Practical tips from exercise to diet. It's a combination of both, right, Professor? It's the dietary and the exercise that is important, but only in child's A. That's what you specifically said. What about in child C? You don't really suggest any exercise for them?
Sorry. Yeah, no, that was not what I meant to say. So the studies so far have focused on patients who have child A, but I think it's very important across the spectrum. What we will learn with time is obviously how these different patients respond differently potentially.
Correct.
So is there a point of futility? But definitely in our hospitalized patients, it's very, very important that we keep them moving as well. I showed you that significant reduction in muscle mass that happens even after 10 days, right? So exercise and activity in that group is going to be very important, and they're often very sick.
Okay, thank you very much.
Can I ask one question?
Yes, please.
Yes, Professor.
Yeah, Professor Tandon, thank you very much for your excellent presentation. Actually, you emphasized the importance of the exercise for the cirrhotic patients. But, you know, cirrhotic patients, they don't have very much ability to exercise by themselves. Do you think that the help of the physiotherapist, what do you think about that?
Yeah, I mean, you know, I would love for all of my patients to have a physiotherapist, but unfortunately, we don't have access to that many. So I think we need to refer when we can, and obviously getting their help is essential. But if not, then we do need to be able to educate the caregivers and educate the patient about some basic activities that they can do to strengthen themselves. Yeah.
Thank you.
So there are no more questions, Professor. Maybe we can wrap it up. Professor Sarin. Thank you, Professor Tandon. It was an enlightening lecture for us. I think basic to it are the use of nutrition and the exercise in our cirrhotic patients. They are basic, but often neglected by our younger colleagues. And I think the importance of it was already elaborated in all the talks. Again, from the Philippines, stay safe. Happy New Year. And I hope everybody has a safe New Year next year.
Nice to see you. It was a great talk.